In specialized vestibular rehabilitation, clinicians frequently encounter a paradox. Two distinct patient phenotypes routinely present with identical psychological and behavioral histories. Node A and Node B share identical psychosocial inputs, high anxiety and type A personality traits. Despite these identical inputs, their neurophysiological compensations for vestibular dysfunction diverge. One moves toward absolute stillness, while the other enters a state of continuous motion. Solving the clinical problem requires analyzing the specific sensory strategy the brain utilizes to navigate its perceived instability. The first condition is persistent postural perceptual dizziness, or PPPD. The second is mal de débarquement syndrome, or MdDS. Clinical recovery relies on looking past the surface-level symptom of dizziness to evaluate the specific maladaptive sensory strategy the brain has adopted. This is the ontogenetic framework, an evaluation of how the nervous system adapts to its physical environment to determine the required rehabilitation path. Because these two conditions rely on opposing sensory compensations, a generic stabilization program often fails to address the specific mask each patient is wearing. A patient with PPPD exists in a state of constant hypervigilance. For these individuals, the brain interprets normal dynamic movement as a direct neurological threat. This creates what is described as toddler terror, a visceral fear that occurs whenever the body moves through space. This schematic shows the PPPD brain's internal gain dial locked in red. To manage the sensory mismatch of dynamic movement, the nervous system adopts extreme service dependency. When the body docks with a stable floor, the somatosensory system grounds anxiety, masking all error signals. When attempting to stand or walk, the brain cannot reconcile movement with its need for absolute stability, causing a collapse of perceived equilibrium. For the PPPD patient, the physical ground is a security blanket used to mask an over-amplified internal gain. The MdS patient suffers from persistent internal entrainment. Inside the MdS brain model, an internal oscillator creates a phantom, ceaseless sensation of rocking, swaying, or bobbing. These patients frequently demonstrate normal sensory strategies on advanced testing for head motion and optokinetic flows, even while the internal gear continues its relentless rotation. To cope, the patient uses active movement or passive transport, such as being a passenger in a car, as an external signal. This external motion successfully masks the internal rocking. When the external motion stops, the internal oscillator becomes the dominant sensory signal in the room. For the MdDS patient, absolute stillness is the primary source of distress because it leaves them alone with their internal entrainment. A healthy vestibular system recognizes absolute stillness, represented here by the thick baseline. The PPPD avatar on the left stays glued to this baseline, unwilling to separate from it. The MdDS avatar on the right hovers unsteadily, unable to dock with the ground. The MdDS brain has lost its 0 point, the ability to process absolute stillness. Attempting to stabilize these patients using the somatosensory system often increases the intensity of their symptoms. The ground is a necessary crutch for the PPPD brain, but an unreachable baseline for the MdDS brain. The ontogenetic framework plots rehabilitation vectors that oppose the patient's maladaptation. The clinical intent for PPPD is to break the patient away from their somatic sensory system. This requires moving them away from the floor and challenging their surface dependency. Introducing instability, as shown by this upward vector, teaches the brain to let go of the ground. Forcing the nervous system away from its mask drives neural adaptation, which ultimately lowers the brain's internal gain. Treating PPPD requires moving the patient toward the movement they fear and away from the stability they use to mask their symptoms. The objective for the MdDS patient is to move them toward stability. The clinician must facilitate the patient's ability to stand, sit, and lie down without internal rocking. They must learn to inhabit a quiet environment without using motion to mask their distress. Moving the patient toward the ground, as seen here, helps the brain find the baseline it has forgotten. The goal is to force the brain to recalibrate its 0 point without relying on external inputs. MdDS rehabilitation demands that the nervous system find a baseline for stillness that it has lost. PPPD patients use the floor to mask the fear of movement. MdDS patients use movement to mask the discomfort of stillness. Coordinated treatment plans must honor these differences to guide the brain back to a neutral state. Ultimately, the final goal of this clinical intervention is a complete recalibration of the brain's physical relationship with the earth. Clinical success depends on recognizing which sensory mask the patient is wearing.